Well, I'm so glad to be able to see you guys this time, having done an interview with you over Skype, which was both exciting and frustrating, and to be able to hear each other and see each other makes a big difference. But I guess I was so influenced by Les Green's presidential address today that I wanted to start there, because I thought what his tone was trying to bring research and clinical practice together to make it a holy matrimony, not a holy acrimony. And I thought that was he gave a wonderful talk. And what he made me appreciate was how it's not such a dichotomy, that we're all clinicians and essentially we're all researchers. Even if we're not doing formal research, we're taking note and measure of what is the effect of what we do. And so this notion of evidence-based practice gets a bad rap. And I wonder if we could have a discussion around that.
I guess not.
Well, not evidence. I'm sorry. Evidence-based treatment gets a bad rap.
Well, it's one of those things that, the question is, of course, what do you consider evidence? And people are going to define evidence quite differently. My patient gets better. How do I know that? Because the patient tells me so. The patient might be feeling that they're getting worse, but I think they're getting better because they're showing more feelings. How do we define evidence?
I think that you're right about the kind of bad rap that evidence-based treatment has received. And from my perspective, it's important to recognize that people who are interested in evidence that involves numbers, for example, are not necessarily naive to the clinical situation or devaluing of a clinical situation. And it's a work in progress. One of the things that, for example, excites me about some of the new data emerging from the empirical research, so to speak, is the focus on being an evidence-based therapist. And what does that mean? It means using the evidence that shows cohesion is correlated directly with outcome. Gary's done some of the pivotal research on that. Empathy, correlated directly with outcome. Tracking what you do, correlated directly with outcome. Those are three things that no one who's a clinician, I think, would say, well, that doesn't speak to me.
I think one of the things that I liked that we played with when we were on our Skype interview, which I want to toss back in, is that I just bet this is true of Scott. I'll see if it is. But I think of evidence-based clinicians as local scientists. I think that was the notion that I tossed out. Mm-hmm. And I bet, Scott, that you're paying attention to something pretty systematically when you make the conclusions. And so to tie that in with what you're saying, Molyn, can we be explicit about what we mean by improvement? And he was. He said, my client's affect is going up. I suspect if we ask your client, they might say, I'm feeling bad because their affect is going up.
And my response would probably be, you're feeling more. But
right. And so from a local scientist perspective, they're both paying attention to the same phenomenon, which is a change in affect.
Yeah. Well, you threw about the notion of feeling more the last time we spoke. And how do you tell a group member why that is useful? Because the initial contact with a greater emotional range is sometimes terrifying.
Yes, somebody will often say something like, I'm having a panic attack, and I might, depending on the circumstance, say something like, it seems to me you're having an attack of humanity. It's a way of kind of normalizing it. Yeah, I don't think, first of all, any clinician would not want to know that there was some way to empirically validate that what we do works. Who wouldn't want to know? Or that what we do isn't working. It would be equally important to know. I think one of the problems that's always been present is, particularly for those of us who work in kind of a process mode, is to find some way of having research methodology that doesn't interfere with the process or isn't perceived as interfering with the process. If somebody takes, has patients fill out forms or something like that, it's like, well, now wait a minute, that's adding another whole variable that I have to consider in some way. But so how do I get the data?
So one of the ways that I've been playing in that space for the last decade or 15 years is to not ever use the word research. And so we talked a little bit about this when we were doing the Skype interview. So Molyn has a medical background, and when you go into a physician's office, they collect data on you, blood pressure, temperature, and whatnot. And the physician doesn't say, I'm doing research on you. The physician is saying, I'm gathering some vital sign information. And when we introduce our group members to filling out quick forms that'll take them 2 or 3 minutes, we don't use the word research. We say we want to do a check-in with you. And the same thing with respect to the therapist. So the first reframe is to not think about it as research. Think about it as that local scientist data that you're gathering anyway, Scott. Does that make sense?
Yeah, it makes perfect sense. And the way in which, in fact, we have packaged that kind of evaluation in our group program where I work is to use the metaphor, the analogy. You wouldn't want to go to your family doctor and have your cholesterol be treated and for the doctor not to do some blood work.
Right.
And so these are our vital signs. So it's important to pick stuff that is easy and accessible. And I think the fear that it contaminates the process, I think with experience you may find that in fact it enhances the process, because one of the things that kind of literature teaches us is that we often overestimate how well our patients are doing, and we miss people who are not responding well. And if you can recognize earlier on, there's a problem in cohesion here for this individual, there's a problem in the alliance, because the group may be cohesive, but you may have an outlier who is struggling, and if you can recognize that earlier than the individual may be able to articulate, then you can begin to intervene. And the evidence, Gary's very familiar with his evidence, he's contributed a lot to it, is that early recognition reduces deterioration effects, improves outcomes. And who wouldn't want that?
So to use the medical model, it's analogous to I may not feel my cholesterol going up, I may not even feel my blood pressure going up, but unless I measure it, I'm not going to know, and there may be trouble down the road if I don't identify it early.
Right.
Well, and just to piggyback on that, yesterday we had a workshop that we did where we had 20 clinicians in the room, and we used the group questionnaire, and I had 6 clinicians on the panel, and they each showed data from their groups, and then instead of telling them what they did in the group, they asked these 20 clinicians, what would you do? And there was some wonderfully creative group interaction around that. So your cholesterol might be going up, but your physician might say, take the statin, or do an exercise program, or. So having a metric doesn't necessarily lead to a specific, maybe the way to say it is a prescriptive intervention. It's data that then it's grist for the mill. And you're going to be creative with your client and your group on how you're going to use that.
So that makes
let me just to play a little devil's advocate. Although I would be happy to have these kind of things done, and I would be sort of interested in the data. But just to think about it from another side, the questions that you ask themselves enter the process, right? Because you're looking for particular things. It's like I always tell my students not to take notes during a session, because the patients are acutely aware when you're writing something down and when you're not. And
so you're going to look at that data, but not this data.
Yeah, exactly. So it's just interesting to think about. Well, how do we ask the questions in a way which have the least impact on the process and give us the maximum information about what's going on.
I would respond, Scott, to that by saying that anytime you do a process check in the group, how are we doing? How are you feeling? How's this going for you? That's kind of the tip of the iceberg with regard to getting a sense of cohesion or alliance. And we can think about incorporating measurement not just about outcome, but about the process. I think there's as much, if not more, to gain as a therapist from tracking process. So you can say, if somebody says, how do you know what you're doing is working? You can say, my groups are cohesive. When there's a problem with cohesion, I recognize it early and I'm able to repair it. And I think that correlates with patients in my group doing better.
One of the ways, I'm sensitive to your concern, because we played with it now for about 20 years in different ways. And one of the least intrusive ways that we do it is we do a process check-in at the end of the group. So I leave and I say, I'm about ready to go and take my notes on this group, because this group session was really important to me and I don't want to forget, and I'll probably bring it back. Would you be willing to do a check-in with me and take about 3 minutes to fill this out? So the group is checking in a systematic way while I'm doing my own check-in by writing notes. And
it's just a matter of how you decide what you're going to check. For example, I'm very aware that every time I make a comment, I'm changing the process too. Yep. I'm teaching the group what I value. Yeah. So I would probably write out a very different kind of questionnaire about, did you feel closer to anybody in the group? Did you feel, what was the proximal distance you felt from people? Did you feel like you belonged in terms of cohesiveness?
Those are the questions we ask.
Yeah, I know. I know you're.
But I would say, Scott, that
I put it in German though, so they
it is in German, and 30 other languages.
I would say, Scott, that you, like the majority of us, is an evidence-based practitioner.
No, I think
because you don't go in without a sense of what to look for. You have a sense that in order for this person to improve, engagement with more affect will be constructive. And so we're guided by models. And this is just another, it's just another piece of that.
Yeah. And that we'd have to be very careful that that the questions are going to sort of be weighted toward one model or another, inevitably.
Yeah.
Yeah. Well, are symptoms weighted toward one model?
I'm just saying you may have to have different questionnaires, different variations depending on what, you're right. I would say I want to be able to say, do people feel they have more skills to allow more people into their life? Do people feel they're better able to love and be loved, et cetera? Those would be the kind of variables that I'm most concerned with.
Well, when we look at the different models, I know that many average clinicians that I've talked to who are more reactive around evidence-based practice think that CBT models are getting all the focus and they're getting all the accolades, and that those are the ones that the insurance companies are focusing on as having the most impact and are therefore reimbursable. And those, just to bring in another area, who are practicing more psychodynamically, I think get very defensive about that and worry about, well, what about us? Are our strategies and is our model being studied, and is it being shown to be effective?
Well, what if I were to say to you that the difference between CBT and an interpersonal model is related to the fact that CBT has a tradition of measurement and relational models don't, but that meta and mega-analyses show that there's often little to differentiate models in terms of effectiveness. It has to do with the kind of evidence that you are collecting. And that we have to, I think, within the organization, I think we have a responsibility to our membership to help prepare for an environment that's going to be more demanding with regard to accountability. And to view it not as a threat that is we can't handle, but as an opportunity that we as an organization, as clinicians, as researchers, can respond to very effectively.
And that an alliance that ultimately would be helpful to both clinician and researcher, because the information goes both ways.
Right.
And I was wondering, for those who practice, who actually engage in empirical studies, what do you want to know from clinicians that inform the kinds of questions you ask, and also as a clinician, what kind of questions do you want to see studied that maybe haven't been yet?
I think Scott's begun to address that by
I thought
saying,
so. Yeah.
how can we measure this without interfering with it too much, without distorting?
We're going to present this tomorrow, Steve. This is the kind of research that I think we're doing that's exactly in line with your question. So we have about 20 clinicians, Scott, that have been in this randomized clinical trial.
Very exciting work you're doing.
And one of the things that we asked them to do is how are they using feedback on the GQ in a session-by-session way. So a part of what we're doing is portraying tomorrow the clinical wisdom rather than saying prescriptively, this is the way to do it. We say, here's how one group of clinicians do it. So clinicians share with us how they use the blood pressure information, and sometimes they choose to not use it explicitly. They just store it, in their frontal lobe and use it intuitively.
That is such a great point. And I think that's where a lot of the resistance in the divide comes from. The idea that research is prescriptive and restricts you. And it can do that, but it can also be empowering, and you can use it to be the best provider, the best therapist possible. And I think that's where I think there's a great opportunity for convergence.
Yeah. Well, and that also implies that there's a greater sophistication being brought to bear on how these questions are studied, how the work that we do is studied. Molyn, I think you brought up in our last interview the notion of the fear of manualized treatments, and I think you said something like, well, manualized treatments, the evidence is not there that specific manuals work, that there's a lot more to the story.
That manuals have evolved from kind of prescriptive to kind of more principle-based, because the prescriptive manuals, you could become adherent to it and lose your competence. Whereas more principle-based manuals, like the clinical practice guidelines that we worked on, kind of operate at a higher level. There's more range of freedom, but there's guidance if you have questions.
In some ways, this reminds me of the early days of group when the analysts sort of said, well, groups won't work because you can't have transference, And there was a great fight because you're going to interfere, it's going to tear the process apart. And then, of course, we realized that you have lots of transference. And I'm sure there are going to be ways in which all this research is going to be able to be incorporated in and seen as grist for the mill and useful, and as well as providing data.
So it's going to give an example of what Molyn was talking about. We just finished a large review that was published in the Bergen and Garfield Handbook. Yes. And you were mentioning or asking about manuals, but a moment ago you were asking about psychodynamic work as well.
Exactly.
What I think is pretty exciting is some of the more difficult disorders are being approached now with what are called integrative models. And so this is taking a psychodynamic perspective and integrating it with a cognitive or a CBT perspective. And so you see multiple theoretical orientations in place in an integrated way, but not in a prescriptive way. It's saying there's something that's important for the patient from a depth perspective, from a thinking perspective, and from a relational perspective. And what's really I like about these models, not only is it happening, but the effect size, the improvement that we see coming out of them are just as good, if not better than using a single modality approach. So it's taking the wisdom of the clinicians he was referring to a minute ago and putting it together.
Right. Well, that really addresses the question.
Yeah.
Very nicely.
Yeah.
I have to say, I know we're about out of time, but again, just like several months ago, I feel a certain excitement and hope for closing the gap. It seems like that's already being done in some of the empirical work that's being conducted, in the way that we're dialoguing. I personally feel hopeful, and my additional hope is that people who see this video will also feel encouraged and not feel so threatened by evidence and evidence-based practice.
I think we can all drink to that.
Yeah,
You're here.
Yeah.
Thank you for calling us together.
Thank you for being available.
Thanks, Steve.
Yeah, thank you.